Okay, well, it's 2 minutes after the hour. I just want to welcome everyone, and I know a few more people will probably be signing on. This is our Doctors for America Advocacy Grand Rounds, and today's session is on Medicaid innovation and population health. My name is Jeff Hebner. I'm a family physician in Madison, Wisconsin, and I serve on the board of directors for Doctors for America. I also, in part of my day job, work as chief medical officer for the Wisconsin Medicaid program. And in that role, I get to work with people like this all across the country. So thanks to DFA for bringing this panel together. And it's great to see a couple of friends and colleagues who are going to be participating today. You're going to love learning from all of them. I just wanted to kind of cap things off or intro a little bit by giving a little background. I know a lot of you are probably very familiar with the Medicaid program, but just as a reminder, Medicaid is a federal state partnership program in the US that provides health coverage now for about 1 in 5 Americans. Doctors for America believes that all Americans should have access to high quality, affordable healthcare. And Medicaid expansion has been a bedrock strategy over the last many years since the Affordable Care Act was passed. And while DFA will continue to advocate for this in the states that do not yet have it, what many people don't realize is that Medicaid is also a catalyst and important driver in covering 1 in 5 Americans for important healthcare innovation that increasingly is making care better through payment innovations, prescription drug access, addressing social determinants of health, and tackling health disparities in our states. So these opportunities are really available in all states, regardless of their expansion status, and we wanted to share more about that today. So we have several wonderful panelists, but before I get started, I wanted to just take a quick minute and invite all of you to officially join Doctors for America if you haven't. If you become a member today, that really means that you're taking the important and simple step of supporting this work going forward with annual membership dues, and you can pay at the level that works for you. There are 6 levels to choose from, and a DFA member is going to put that information in the chat. We also wanted people to know that we'll be live streaming this on Facebook Live. We'll also make a recording and make materials available after the session. Just a few quick ground rules for the session. No such thing as a silly question. And as you're thinking of questions along the way, as I said, we're going to have 4 panelists. We're going to let each of them present, and then we'll do Q&A at the end. But feel free to jot a question down and type it in the chat later, or if you'd like, you can type it in the chat along the way, and I'll try to come back to that then when we do Q&A at the end. Our panelists are from across the country: Louisiana, North Carolina, Washington, and Oregon. And our first panelist is going to be Ms. Allison Evans. Allison is the Policy Director and Director of the Medicaid Evidence-Based Decisions Project at the Center for Evidence-Based Policy in Portland, Oregon. She joined the center in 2019, and prior to that, she served as Policy Advisor and Staff Counsel for Texas Health and Human Services. She earned her JD degree from the University of Wisconsin, go Badgers, and I'm happy to turn it over to her.
Great, thank you so much, Jeff. Well, I'm delighted to be here with you all today and to have the opportunity to offer a national perspective on Medicaid innovations around social risk factors and also around value-based care. So if we go to the next slide, before I jump into this area, I wanted to just provide a brief background for why I'm able to offer this perspective. So I'm with the Center for Evidence-Based Policy, and we're part of Oregon Health and Science University. We're not funded by industry or associations, and instead we're fully funded by states, with the majority of our work in Medicaid. So we're nonpartisan and we don't lobby. If we go to the next slide, in particular, the information I'm going to share with you all today is from the work we have done for our Medicaid Evidence-Based Decisions Project, which is a collaborative of 21 state Medicaid programs that come together and they pool their resources to fund research that helps them more effectively use reliable, high-quality evidence in the design of their program benefits and coverage policies. So on the next slide, you can just get a sense of the states that are a part of this collaborative and how they represent not only each region of the country, but as Jeff was speaking to, both expansion and non-expansion states. So I'm going to be drawing on all of the research that we've done for these states in this presentation this morning. So first, we're going to look at innovations in addressing social risk factors. And on the next slide, you can see we've got non-medical social needs such as food and housing generally fall outside the traditional purview of state Medicaid programs. But in recent years, especially during the public health emergency, Medicaid programs have been looking at innovative ways to address these social risk factors for the populations that they serve. They've been able to expand these services in part due to the expanded authority and flexibility at the federal level to use Medicaid dollars for addressing social risk factors. So CMS, or the Center for Medicare and Medicaid Services, released guidance in 2021 that outlined the various ways state Medicaid programs can address these social risk factors. And this includes food, such as through home delivered meals or CSAs, housing, so you can think here temporary or permanent modifications to a home to improve an individual's ability to remain in their home or their community. It could also include security deposits. Medicaid programs can also pay for non-emergency medical transportation, so transportation to employment, for example, and also for care management services, so in particular around screening and referrals in partnerships with those community-based organizations that provide services to address these social risk factors. So that's the area I'm going to turn to next and just spend a minute highlighting states' work in this area. So screening and referral processes are well documented in the literature, and they've consistently been found to be effective in identifying individuals with unmet social needs and connecting them with those community resources that are outside of the healthcare system. But there's been a disconnect historically between the healthcare system and community-based social service needs organizations that has further perpetuated that gap between screening, referral, and the receipt of social services. So the vast majority of screening and provider referrals has traditionally been unidirectional, meaning providers such as yourself are sending CBOs information about patients needing services, or have included a list of service providers and patient discharge summaries. But with some exceptions, those community-based service organizations haven't been able to close the loop on those referrals by sending information back to the referring provider about whether the patient obtained services. And without that ability to close the loop on referrals, providers, and I'm sure many of you have been in this position, are left wondering whether their patients ever received the services that they needed. So state Medicaid programs are now working on facilitating closed loop referral systems, which would allow providers to track whether the patient received the services requested, and then whether those services had the desired effect, which would help optimize care planning and enable evaluations of the effectiveness of those social service providers. So on the next slide, you can see, oh, sorry, if we can go back one, I apologize. Thank you. So the use of closed loop referral systems is pretty new for state Medicaid programs, with only a few states currently pursuing and operating those closed loop referral systems. So there are a handful of states currently that are looking at this, and they're in different phases of the process. So you've got some that are looking more at the planning and development stage, like Arizona, and then you have other states that are further along and looking more to the implementation and maintenance phase of a closed loop referral, such as Michigan. And while there's great interest from states, as you can imagine, to use closed loop referral systems to address social risk factors, there are many challenges to implementation, including data collection and integration, particularly with community-based organizations, many of whom don't have the sufficient technological capabilities to interface with those existing systems. But we think with additional funding and training, particularly for those community-based organizations, the use of closed loop referral systems for addressing social needs has the potential to connect the disparate healthcare and social service sectors to expand Medicaid's ability to address those social risk factors, and look forward to seeing more work on this from states in the future. So next, I'm going to talk a little bit about innovations in value-based care. The state Medicaid programs across the country are increasingly focused on moving away from fee-for-service care towards value-based care that focuses on quality of care over volume of care, which I'm sure you're all very familiar with. And in particular, in recent years, state Medicaid programs are turning to alternative payment models for high-cost specialty drugs to treat serious conditions such as cancer and hepatitis C, which you're going to hear a little bit more about in today's presentations. Additionally, Medicaid programs are striving to provide better access to care through value-based payments around maternity care. And for example, some state Medicaid programs have perinatal episode of care models that focus on neonatal care offered in those immediate days following a baby's birth. And as you all know, given current public health challenges, state Medicaid programs are trying to determine how to control costs while providing effective care around long-term services and supports, and also for treating opioid use disorders. And another area where states are focused on value-based care is primary care. And you're going to have an opportunity to hear about the work that Washington has done around this a little bit later from Judy. And then I wanted to just briefly highlight some innovations around value-based care for care coordination, because states are really increasingly focusing on this area as a place to improve population health for the Medicaid population. So there are a variety of mechanisms states can use to provide, structure, and pay for care coordination services. In terms of value-based care coordination services, states are increasingly turning to two different models. You can see those here: accountable care organizations and health home models. So ACOs, as I'm sure you all know, are groups of doctors, hospitals, and other healthcare providers that are voluntarily coming together to provide that high-value coordinated care that's so needed for patients. And currently in Medicaid, there are about 14 states that have organized accountable care organizations. States also provide value-based care coordination through health home models. These were created under the ACA to coordinate care for Medicaid beneficiaries who have chronic conditions. So you can think care of mental health conditions, substance use, diabetes, heart disease. And I've got an example here. Michigan Medicaid has established 2 health homes. They've got one focused on behavioral health and the other on opioid use disorder treatment. And then finally, state Medicaid programs are turning to population-based payments to pay for care coordination through these accountable care entities and the health home models. So states, they use a standard per member per month payment arrangement. They're also using bundled payments or global arrangements. So for example, Michigan Medicaid, those health homes I was just talking about, they pay providers using a monthly case rate through the opioid health home, but it also includes a pay for performance withhold. So we're likely going to see an increased focus on value-based payments for care coordination, and in particular care coordination, not only for medical services, but also connecting back to those social services that I was just describing. So if we go to the next slide, hopefully this gives you a sense from the national perspective of how state Medicaid programs are innovating around social risk factors and also value-based care. I've provided some links to our research in case you're interested in learning more, but now I'll turn it back over to Jeff.
Thank you, Allison. And sorry, I think I might have, in my zeal about Wisconsin, misstated your credentials since you got your law degree at University of Texas. So undergrad at UW. Thank you so much. That was an amazing summary of an expansive area that we tasked you with. So that was wonderful, and look forward now to hearing some more specific examples at the state level of this work. So I'm really pleased to introduce longtime DFA member and former board member, Dr. Joseph Cantor. Joe is the state health officer and medical director in the state of Louisiana, and as such serves as their top medical official in the Department of Health, where he helps consult on issues related to policy, quality, access to care, health equity, emergency preparedness, and infection control. Prior to that, he served as director of health for the city of New Orleans and led Mayor Mitch Landrieu's comprehensive opioid mitigation strategy. Joe is an emergency physician by training and still seeing patients. Happy to turn it over to you now, Joe.
Jeff, thanks so much, Allison. Thanks for a really great presentation. It's really nice to be back with my DFA friends. I do want to just start by thanking you for what you do. It's really never been more important for physicians to stand up and support the issues that you do. One thing I've realized through the COVID experience is that the void will be filled by someone in terms of the public and the political role of a physician speaking their mind. It'll be filled by someone. It might as well be someone who knows what they're talking about and is talking on behalf of patients and their best interests. So thank you for what you do. It's never been more important. I'm going to try and give a little state perspective of how the Medicaid program can innovate and interact with other health initiatives that a state faces. Next slide, please. The Louisiana Department of Health is a large umbrella department. Not every state is set up this way. Many states have these various components: Office of Public Health, Office of Behavioral Health, Medicaid. Many have them separated out into distinct cabinet level departments. Louisiana, like a number of other states, have combined those into one large department. There are pros and cons to that. I through my time here, have come to realize it's a real advantage if it's used in the right way. And I'll explain what I mean by that. Next slide, please. It's a very large department. It's about 17 or $18 billion department. That's the larger pie you see. The smaller pie you see is the breakout of what the Medicaid program specifically represents. It's about 90% of the overall department's budget. Vast majority of that is federal funding, federal match. But the point here is that when you have Medicaid as part of a larger health department, the overwhelming majority of the funds of that department are the Medicaid program. It's the largest financial component for most departments. That brings in a lot of resources and expertise that the other aspects of the department, public health, for example, or behavioral health, can benefit from. It also means that those other wings of the department help influence Medicaid's policy and Medicaid's perspective on things. I have found that to be very beneficial when we talk about how Medicaid can do more than just provide coverage, when it can actually be a driver for health impact. Next slide, please. One example that we've dealt with a lot in Louisiana is hepatitis C, and we've done some good work here I wanted to share. So there's about 50,000 Louisianans living with hepatitis C, and the issue is that since the direct-acting antivirals came on the market 15, maybe even 20 years ago at this point, they are curative, which is a groundbreaking issue for treatment of hepatitis C, but exorbitantly expensive, particularly when they first came out. When Harvoni first came out at Gilead, the initial list price was $94,000 for a course of treatment. Because of that restrictive cost, many Medicaid programs, particularly Medicaid programs in lower income states like Louisiana, resorted to restrictive eligibility criteria as a means of mitigating cost. Criteria which were in no way evidence-based, that just simply served as restrictive of who would qualify for direct-acting antivirals. The same can be said in correctional facilities if the medications were offered at all. In many correctional facilities, they just simply weren't offered. The end result of this is that the most vulnerable people, at least in Louisiana, were denied treatment to a life-saving medicine. And anyone that has worked in ICUs knows that liver failure is just a horrible way to die. One of the worst ways I think you could do it. Next slide, please. This is a real sign. It's in the airport. It was in the airport of New Orleans until about a year and a half ago. We had a lot of liver failure in Louisiana, and the most painful part about that is that there was a treatment available that the most vulnerable people of our state, until we instituted this program, were denied access to. Next slide. The solution that we instituted was a subscription model. And in partnership with Gilead and their subsidiary, Asegua Therapeutics, we negotiated what was been called the Netflix model of pharmaceuticals, which is instead of us negotiating a per patient or per dose rate, we negotiated a all-you-can-use model. We essentially paid $35 million a year over the course of 4 or 5 years for all the Hep C direct-acting antiviral that we could use. There's a novel use cases, but a number of states which have pursued this since then, but it created the opportunity to treat every Medicaid recipient and every inmate in the Department of Corrections statewide that we physically could treat. So change the script on that. We entered into this partnership in 2019. It was a good partnership between the Department of Health and the Department of Corrections, two agencies which before this did not have a great track record of partnering together. And between those two agencies, Medicaid recipients and inmates under the care of the Department of Corrections, we estimated about 39,000 people who were living with hepatitis C. We set a goal of treating and curing 31,000 patients by the end of 2024. next year. This was not just a pharmaceutical pricing program. It was coupled with an extensive screening program to greatly increase the number of people who are being screened for Hep C and the settings in which they're being screened at. It had a robust case management program to help navigate patients from screening into treatment and supportive care if they need it, and a clinician training program. You don't need to be a hepatologist to treat with these medications, but a lot of providers, clinicians needed to be trained on. That was all part of the program. We also updated the sanitary code in Louisiana to mandate reporting of negative Hep C screening tests, as well as confirmatory viral loads. Prior to this, a positive Hep C test in Louisiana was required reportable disease to the Department of Health. After we updated our sanitary code, essentially any type of Hep C test, negative, positive, or viral load, was reportable to the Department of Health. Those last two things, the screening program, the case management, the training program, and then updating our sanitary code, those are not things that the Medicaid program would have had an easy time doing if it was a standalone department, as it is in some states. Because it's within this larger health department umbrella, it was easier to partner with the behavioral health office and the public health office and the health standards office, which deal more in those issues and have a lot of expertise related to that. Next slide. This is a graph showing essentially our incidence rate of new Hep C diagnoses over the years. You can see that once we updated our sanitary code and increased screening throughout the state, the number of Hep C cases being diagnosed and reported in Louisiana increased about fivefold. So you certainly can't attack any disease unless you know about it, and you know who has it, and you can reach those people. And that's what changing the law here and then adding the screening and case management apparatus allowed us to do. Next slide. So since the launch, there's been just over 13,000 people who have accessed Hep C treatment through this program. 11,000 have been through Medicaid, and just shy of 2,000 have been incarcerated individuals through the Department of Corrections. Through the surveillance data that we have, we know that we've got about 15,000 Medicaid recipients who are Hep C positive, have active disease, a positive viral load, but have not yet accessed treatment. So that's the population that we're still going after right now. So caveat being, some of these might have accessed treatment through another avenue that doesn't flow through Medicaid or Department of Corrections, but that's likely to be a minority. But that's the real target of people that we're still trying to reach, but we haven't been able to reach yet. Next slide. One of the things that was important to us is accountability. We have a managed Medicaid program in Louisiana, as many states do, where Medicaid programs are administered by one of a number of managed care organizations. So if you're a Medicaid recipient, your care is actually being managed by one of these private insurers. It used to be 5, now we have a 6th one in Louisiana. We tracked their progress and their efficacy in getting patients screened, managed, and treated with Hep C medication. We put this data out publicly every month. So we call for a lot of accountability from our managed care organizations. And for the outliers here, you see LA Healthcare Connections and United are outliers with the most patients yet to be treated. We put the pressure on them and make them publicly explain what they're doing to help correct that. Next slide. This is a course of essentially the progress and success of the program from initiation in 2019 until current day. And you can see from the graph that we really had a setback when COVID hit. Like a lot of health priorities, unfortunately, our progress in identifying Hep C patients and getting them into treatment really stalled throughout the pandemic. And unfortunately, we've not been able to regain the level that we had prior to the pandemic hitting. And that's a focus of concern and energy for us right now. Next slide. So some lessons learned from our Hep C subscription model. The first is to maintain anchorage to the bold vision. When we talk about this initiative and when we enlist partners and motivate on it, we're not talking about reducing barriers to accessing pharmaceutical. We're not talking about reducing clinician paperwork or prior authorizations, although all of those were helped by this. We talked about eliminating hepatitis C in Louisiana, because that's really what we have the potential to do. So we, as much as we could, kept coming back to what the ultimate bold vision was. We felt like that helped drive internal and external buy-in throughout the process. Important to seek out and leverage partners. None of this can be done by a Medicaid program or health department alone. We needed the partnership of many different partners: corrections, primary care physicians, hospitals, you name it, across the board. Really important to seek out as many partners as possible. One thing we learned was the importance to plan for contingencies. Tough to plan for a 100-year pandemic, but there's always emergency, there's always distractions, and for a multi-year initiative, certainly a high priority one, lesson we learned is expect that there will be distractions, plan for that, have a contingency for that. And then the last lesson I'll say is, it's never wrong to overinvest in wraparound and supportive services. After we got the subscription model up and running and essentially took the pharmaceutical cost off the table, we realized that the real heavy lift after that was in case management and training clinicians and nuts and bolts beyond just reducing the barrier to the medication itself. That proved to be a much larger lift than I think we anticipated. So although we did invest in these issues and built programs around there, I think we can and should have done more. Never underinvest in the wraparound and supportive services. That's ultimately where the last mile of reaching patients. That's where the real challenges become. Next slide. I do want to talk just a second about the role of our Medicaid program throughout the pandemic. Because the federal public health emergency disallowed state Medicaid programs from taking anyone off the Medicaid books. You cannot be disenrolled from Medicaid, and that will hold until the beginning of April. Our Medicaid rolls swelled. Right now, 42% of the state of Louisiana is on Medicaid. So when you have an issue like COVID, that's a lot of opportunity. You touch a lot of patients. So we instituted incentive programs for the COVID vaccine, both large dollar lottery incentive programs and small dollar incentive programs, and they were effective for us. They were controversial, but they were effective. And we, the Medicaid population in Louisiana is vaccinated at a higher rate right now than the general population of Louisiana is. And next slide, please. And the last thing I'll note on a related note is, the states surrounding us are really struggling with hospital closures, particularly rural hospital closures. American Hospital Association put out a nice report a few months ago that showed that 75% of rural hospital closures in the past 11 years nationally were in states that did not expand Medicaid. Since we expanded Medicaid in 2016, it was the very first thing Governor John Bel Edwards did when he took office, his first executive order. Since we expanded Medicaid, we've not had a single hospital closure in Louisiana. So when you talk about innovating, when you talk about pursuing health initiatives, it's tough to do that if you're putting out fires, like dealing with hospital closures, dealing with just how to provide care to patients. So the benefits of expanding Medicaid have really never been more apparent than they are now. So I'll pause there, and Jeff, turn it back over to you.
Thanks, Joe, for sharing that very inspiring work. That's great. Maybe we'll get to talk a little bit more during Q&A. So I'm really happy now to introduce Ms. Pamela Perry, who has over 25 years of experience working in Medicaid policies and programs. She currently leads government affairs for Carolina Complete Health, a Medicaid health plan in the state of North Carolina. In previous roles, she's held many roles in leadership in the public and private sector in healthcare, including with HHS's Bureau of Primary Health Care. She worked as an analyst at the CDC and also at the Substance Abuse and Mental Health Administration. She received her master's degree in public administration from the University of Georgia, and it's great to welcome you, Pamela.
Thank you, Jeff. Really appreciate that. And it's really nice to follow Joe, because I'm going to drill down and provide a state case study of sorts around Medicaid expansion. And we're one of the holdout states, as you all know, but there's been progress, and it's been an interesting road to get to where we are today and where we hope to be in the not too distant future. So let's get started. Next slide, please. To start out, North Carolina has been studying its Medicaid program for many, many years now. Most recently, North Carolina launched the Medicaid Managed Care Program. And I'll just mention that Carolina Complete Health is a provider-led plan that is a partnership model, joint venture between Centene, which is the nation's largest Medicaid managed care company, the North Carolina Medical Society, and the North Carolina Community Health Center Association, which manages the federally qualified health centers in the state. So it's a great partnership, bringing the provider voice to the table in a way that I think is unique and meaningful. And we are really excited about doing business here in North Carolina after many years of getting the program underway. So as you see here, the North Carolina General Assembly and North Carolina Department of Health and Human Services have been working on Medicaid transformation, they called it, for many years. The original legislation to authorize the move to managed care was passed way back in 2015, and key legislative components that were needed for licensure and behavioral health integration and things like that were passed in subsequent sessions. I will note that North Carolina requires legislative action for most initiatives, including, any major program change or policy direction, all appropriated funds, including those for COVID over the last couple of years, economic development, et cetera. So any action in the state must be approved by the General Assembly, we call it here, the legislature. Other states have pretty broad authority for the governor. We do not. And in North Carolina today, we have a difference in the composition of the bodies. So the Governor Roy Cooper, is in his second and final term. He's a Democrat. Both houses of the General Assembly, House and Senate, are controlled by Republicans. In this last election in November, the Senate acquired enough members to have a supermajority. The House is one vote shy, but they hope to have a functioning supermajority by bringing in Democrats to override vetoes. And just to note, the governor has vetoed, I think it's 47 bills over his term that have been sustained. So this is going to be important, because as you get into policy matters and legislation that the governor may not agree with, he does wield that veto pen, but unfortunately, well, right now it does not have the power that it had pre-November 8th. So we rolled out the managed care program in 2021. You see there are 5 plans. We're one of the 5. We're the only provider-led plan, I should note. The state allowed 2 different types of bidders, sort of traditional commercial plans and provider-led plans. And we prevailed as the only provider-led plan, but you have 4 commercial plans, they're called. And about 1.7 million are enrolled. These are most of your Medicaid population. There are some folks who are not included in managed care at this time, the dual eligibles, those in certain waiver programs and so forth. We will, I'll say, and I'm sure if there are any North Carolina folks on the line, you may certainly weigh in here, but implementation for our managed care program in North Carolina, I think because of the just the fact that we were one of the last large states to roll out managed care, there's been a lot of study, a lot of thoughtful dialogue and debate about what model works best for North Carolina. It was seen as smoother than a lot of other states, at least on, in terms of initially rolling out the program. We did have a delay of 20 months in terms of when we were originally due to roll out. We did roll out in July of 2021. The program does include, for the very first time in North Carolina, integrated behavioral health and substance abuse, value-based purchasing arrangements with providers, and social determinants of health initiatives that are the first in the nation to be approved by CMS as part of our 1115 waiver that governs the program. So really excited about that. Not only did we get approval and waiver authority for those SDOH initiatives. They're called the Healthy Opportunities Pilots. We did get federal funding as well for those, and those have rolled out within the last year. Looking to the future, and just to note, again, as we talk about Medicaid expansion, this infrastructure created by the managed care plans and the relatively smooth implementation of the rollout are seen as critical to considering adding an additional 600,000 or so individuals to the Medicaid rolls. So again, this infrastructure is seen as the vehicle for any Medicaid expansion into the future. We have what are called the behavioral health IDD tailored plans. Those are due to be implemented in April of this year. They are, consider them specialty plans for those with significant behavioral health, IDD, substance abuse needs. And then in the future as well, potential for a statewide foster care and the dual eligibles. The dual eligibles are, as I mentioned earlier, a component, a population not included in managed care today. Next slide, please. And so for expansion, again, about 600,000 enrollees projected, the low-income parents, childless adults, and low-wage workers. The holdout states, if you will, in the last year or so were kind of enticed with some additional federal funding, $1.5 billion signing bonus, I guess we can call it, that could be used for any kind of state identified initiative. So it goes to the state general fund. It's not necessarily going to be applied to Medicaid, but a lot of legislators and the governor has weighed in on how they'd like that funding directed. If, you know, again, we get the signing bonus, it's unfettered with, you know, requirements and things like that. And we can target them in the way that makes the most sense for North Carolina. And then there's in one of the bills, there's an additional funding for hospitals to the tune of over $3 billion for hospital access and stabilization. So a lot of money on the table, a lot of conversation about, you know, who would be part of this expansion population. And then, you know, again, we already have identified the model, the vehicle again, to, you know, the infrastructure created through managed care. So hopefully, you know, that's been a key part of the conversation. So next slide, please. So as North Carolina, as I mentioned, had kind of a long path to getting Medicaid transformation off the ground, you know, many years of study and legislation and things like that. With Medicaid expansion, they have studied it as well. And last spring, there was a joint committee on access to healthcare and Medicaid expansion. And they met about 6 times and looked at different components of, you know, what it would take to launch Medicaid expansion in North Carolina, looking at what the population is, what the costs may be, what incentives to increase. So you have, you know, potentially 600,000 new beneficiaries. How will you structure things in terms of meeting, you know, capacity, both in institutions and hospitals, as well as providers, capacity, meeting needs in rural areas that are medically underserved. We have, I think it's about 80 out of our 100 counties are considered health professional shortage areas, either for primary care, specialty, or behavioral health. Probably not a big surprise to this audience, but you know, it was definitely something that got a lot of attention in these conversations that were had last spring. You see here 4 different states that were used as case studies, if you will, 4 states that have expanded Medicaid and their experience and some of their innovations and their advice were shared. And the picture there, by the way, is former Governor John Kasich of Ohio, who really, you know, that's his quote up there that says, "Great states can do great things," really talked about some of the outcomes and the actual expansion and the provider capacity for Medicaid in Ohio. And so again, they had several meetings on over a period of several weeks as they dove into their short session last year, which yielded legislation, which we'll get to next. Next slide. And so there are two bills that were proposed, the Senate bill, and the reason the Senate bill has a House bill number and the House bill has a Senate bill number is because they were, there's a process called committee substitutes, and they basically took a shell bill, if you will, and kind of stripped it and made it a new bill. And so that was interesting. The Senate bill really went straight ahead and expanded Medicaid. It implemented a work requirement, but it was severable. So basically at the time, this was before Georgia's recent experience with work requirements getting approved. At the time, the federal government was not approving work requirements, but they put in a work requirement and basically said, if it's not approved at the federal level, this initiative will go forward. So it was severable. And the Senate bill really paid attention to some of the regulatory changes that would need to happen to make this all work in terms of expanding provider and infrastructure capacity in the state. So repealing certificate of need laws, expanding practice authority for advanced practice nurses, covering a greater range of telehealth services, higher payment rates for hospital. This is separate from that HASP, that $3.2 billion that I mentioned in the earlier slide. And then notification for a procedure if a provider is out of network. If you go to have a biopsy and the hospital's in network, but the provider is not, that you're notified so that you can make a decision about what to do there. It passed, as you see, with a pretty wide margin. Only one vote against on June 2nd of last year. And then the House bill didn't automatically expand Medicaid, but it created a oversight committee to kind of look at it, look at the issue and do a little bit more study. And also allowed DHHS, or state DHHS, to negotiate with CMS about what features in an expansion bill could get approved by CMS and then come back to the table and have an approval vote on Medicaid expansion later. It did not have any of the regulatory modifications that the Senate bill had, but it did have that HASP, that $3.2 billion payment for hospitals. And then that $1.5 billion budget sign-on bonus that I mentioned earlier, this bill directed $1 billion of that funding to behavioral health and substance abuse projects in the state. And that bill passed its body by a very strong margin late June of last year. So what happened? What's next? So here we are. We had a new session that began in January of this year, obviously earlier this month, and all things start from square one. We're in a new legislative session, so those two bills do not continue. They'd have to be reintroduced or modified and reintroduced and that sort of thing. This picture here is that's Governor Cooper as Charlie Brown. He has been a longstanding proponent of Medicaid expansion. It's been something he came into office advocating for and continues to this day. And that is Senate President Phil Berger as Lucy with the football. And he has come around in the last year to supporting Medicaid expansion after being perhaps its most staunch opponent of it. And earlier this month, early this week, I was listening to a podcast and that he was on, and he said, we're in the red zone. We're getting there. We'll get this done this year. So where are we? So as I mentioned, those regulatory reforms that were in the Senate bill that are not in the House bill really became the focus for negotiating with the House, between the Senate and the House. And the Senate basically said, you can either do the expanded practice authority for nurses approach or the CON reforms. Pick one and we'll incorporate that into the final bill. House picked the CON reforms. The hospitals proposed a reform model in September, but it was rejected by the Senate. So that hasn't gone anywhere. And both Senator Berger, as I mentioned, he's bullish on expansion. House Speaker Moore is also saying he thinks they can get it done this year. We believe that the certificate of need compromise is within reach now, and there may be legislation specifically on it to kind of get it away from the Medicaid expansion conversation as a standalone bill. We are one of the states with a 20-week abortion provision, and both legislative leaders in the House and the Senate have said they want to modify that in some way. So I expect to see some abortion language in this bill again. And Governor Cooper is a pro-choice governor. This is something he probably will not be a fan of, but if he wants Medicaid expansion, to bundle it with something he doesn't want, so it increases his likelihood of signing, is probably an approach that will be taken, if I had to bet. And then another question is, again, whether it will be a standalone bill to kind of move on its own, or whether it will be included in the budget. We have a budget year this year in North Carolina. We're a biennial budget state, and the budget usually gets passed later in the long set. We're in the what's called the long session. So you're looking at June, July for the budget process to play out optimistically. It could go beyond that, of course. If you have a standalone bill, then you can get that. If that gets passed and adopted, then a couple of things can happen. Obviously, you get Medicaid expansion quicker, but also Medicaid redeterminations, as Joe had mentioned, they're coming up, and we're expecting to see a loss of about 300,000 beneficiaries off the Medicaid rolls. If we're resuming redeterminations in April, the first folks would fall off the rolls in July. If Medicaid expansion happens earlier in the session, then you can potentially negotiate with CMS to delay the timing for redetermination, so you have that smoother, softer landing for folks who otherwise would be in the coverage gap. So so there's that. And then sometimes we saw most recently where South Dakota expanded Medicaid by a ballot measure. Oklahoma did last year, Missouri did the year before that. Could North Carolina do it by ballot measure? No. And that is because it would require a 2/3 majority of the General Assembly to allow it, and they are not going to do that. So I think they definitely want to, the legislative leaders want to kind of handcraft this approach, and so that will not happen. So it really depends on timing. You know, again, everything I'm hearing is it's a matter of when, not if, for this year. But again, we hope this is the year for Medicaid expansion. I'm going to skip over the last. So this last slide was about that expanded practice authority. I thought this audience would be interested in that, and I can definitely go back to that in the Q&A. But I will yield the rest of my time, if I have any left, and turn it back over to Jeff. Thank you, guys.
Yeah, thanks so much for that update on North Carolina. Fascinating work going on there. So I'm really excited to introduce, last but not least, Dr. Judy Zerzenthal. Judy and I have known each other going back to our medical student days. I know there's some medical students in the audience, and many of you can become leaders like Judy someday too. Judy is the Chief Medical Officer for the Wisconsin Healthcare Authority, which administers the state's Medicaid program and the state's employee and retiree benefits, which covers state employees and teachers there. She's a general internist, and prior to that work, she had a similar role in the state of Colorado for several years. She's held several leadership positions on national committees dealing with health policy and population health, and I'm really excited to turn it over to Judy.
Thanks, Jeff. And you said I was from Wisconsin. I'm from Washington, the other W state, but Wisconsin's a good state.
Sorry about
that. As we started our conversation. So I have been in Washington state for about 4.5 years. And one thing I definitely want to say is that I feel like I got my start as a resident working with a state on an elective. And Washington State definitely offers opportunities for medical students and residents to spend a rotation with us and learn a bit about health policy and Medicaid. And the other states that I've worked in have also done that. So if you're interested, I know that was in the Q&A, you might want to check that out. And I think states really are the place where a lot of innovation happens. And then some of that gets put into federal bills eventually, like the ACA. And this is our vision, mission, values at the Healthcare Authority. And you can see that innovation is one of our values. Next. As Jeff said, we are the state's largest healthcare purchaser. So we have about 2 million Medicaid lives. And then the rest, we have about 850,000 public employees, school employees, and retirees. So that allows us to do a lot of really interesting things by having that many lives covered as we work with our health plans. Next. And we have really taken the approach of one HCA, so across Medicaid and our other state lives, of thinking about how do we transform care, get better health at a lower cost, focused on whole person care with integrated behavioral health, and then using data to inform our purchasing. And next slide, we have been on a long journey of value-based purchasing. How do we get away from fee-for-service? How do we pay for things differently that will hopefully lead to care being delivered in different ways that work both for the clinician and for the person receiving care? So you can see we started this in 2016 and we've had a map and we haven't quite hit our goals, especially COVID gave us a hit there, but we are actively on this journey. Next. So as an example of that, I have sort of two things I want to talk about that Washington is doing. One is, and I should have changed the title because what the heck is PCTM? That is our primary care transformation model. And for the last 2.5 years, we have been working with payers or health plans and clinicians to develop this model. And now we're also working with employers with the goal of really improving the care of primary care in Washington State, with the vision that primary care is whole person, integrated health care provided by teams and resulting in the quadruple aim of better health, lower costs, better patient experience, and better experience of the clinicians taking care of folks. Next. So how this will work is that participating clinics will be certified at one of 3 levels. With 1 is you're starting your journey, and 3, your advanced primary care. And then payers, both insurance carriers and third-party administrators, are going to support those practices as they move to higher levels. So at the beginning, there might be transformation funds to help you figure out, how do I do integrated behavioral health? And at level 3, there is ideally a per member per month or a population-based payment that just covers the breadth of primary care services in that practice. So it really gets away from fee-for-service and allows much more flexibility for kind of types of care that happen. So the payers will be in alignment, and then there's an aligned set of quality measures so that practices don't have to sort of focus on what they do. So next slide. So this sort of shows all the different folks that are working on this. So there's the payers, and we have 9 payers that are working with us across the state, which is super exciting. There's the primary care stakeholders, so clinicians and health systems, and this includes doctors, nurses, physician assistants, rural, urban, sort of the whole spectrum. Ourselves, and then lately we've added this healthcare purchasers, so employers who buy insurance on behalf of their employees. How do they do that? And I think all of these coming together really help get us to an improved primary care state. Next slide. So this slide just shows those sort of 4 legs of the table, so to speak, and how the different folks involved in this can help. And since Medicaid is probably the biggest part of our business, this is the big part of this business, of how do we provide better care and what does that look like? And so there are accountabilities in each of these boxes that sort of says what folks should do. Next slide. So the next thing I want to talk about is, and folks haven't talked about this yet, but one way that states can innovate is by an 1115 waiver. And these waivers let states change the rules and have different ways of delivering services. And so they're really kind of the prime vehicle to work with the Center for Medicare and Medicaid Services to do things differently. We had an 1115 waiver approved in Washington about 5 years ago that created these accountable communities of health. Our state was divided into 9 regions with 1 in each, and this entity was really charged with providing population health and connecting healthcare to social resources and things like that. And so we are now renewing that waiver for another 5 years. And these are our 3 main goals. And I'll go into them a bit more on the next slide. So next. So the first goal is expanding coverage and access to care so that people can get the care they need. And some of the things we are trying to do is to allow continuous enrollment for kids, so until age 6. So whenever a kid gets on, they stay in Medicaid until they're age 6, which allows for much better coordination of care and prevents kids from dropping off Medicaid. We are also working on ways to ensure a tight connection for people getting out of jails and corrections. We have, and actually other states now have done this too, because the federal government has changed some of its rules, that people who are pregnant can be eligible for Medicaid for 12 months after delivery. And then one thing that's not on here, but we had a state bill pass last year with some funding, where it'll probably take another bill this year to get it all the way across the finish line, but that would expand coverage in a state-only funds fashion for people who are undocumented. In Washington state, that's sort of the last sliver of people who don't have health insurance. And so we are trying to figure out how to make a plan for them. Next slide. So our second goal is advancing whole person primary care, preventative, home and community-based care. And here a fair bit of our work is in the long-term services and support section, so older adults. And then also there's a bit more we're doing on integrated physical and behavioral health, including the use of a tool that will hopefully help practices, both physical health and behavioral health practices, move closer towards integration. Next slide. And then our last goal for the waiver is accelerating care delivery and payment innovation focused on health-related social needs. This is where we started, but we are really working on how do we support those kinds of services that support health that are not directly health-related. So housing, food, transportation are probably the most common that we deal with. And so this will help advance those partnerships and things like that. So I'm going to kick it over to Jeff. I think we're out of time, but I am happy to answer questions later. So.
Thank you so much, Judy. Yeah, well, I know we're at the top of the hour. So in respect to our panelist time, I completely understand if anybody needs to drop off, and just want a quick thank you, all of you, in case one of you do has to drop off. And likewise, I realize some of our members who are signed on may have to drop off as well. But I think I'll at least be able myself to stay on for probably 5 to 10 minutes if any of our members are interested to discuss, and I'll welcome the panelists to do so if they're able to. I see that we did have a question that you started with, Judy. It looks like it might have come from a medical student. Spencer, what recommendations do you have for students and residents who are interested in the areas of value-based payment innovation and health and social care integration and are looking to engage in this space? Perhaps you and Joe have other comments, or others.
Sure, I'll start. You know, thinking back to my own journey, through medical school and residency and into more policy, public health, and political work. I think, just start getting involved in anything. I found that opportunities beget more opportunities. And the more that you get to know your local health department, the more that you get to know your state representatives, and those are, I think, low barriers. You can get to know them and find common ground. One connection will lead to more connections, and you'll find opportunities that might not be the ones you thought you were going to be finding, but you'll find more opportunities if you just start making connections. Local health department, local elected official, that's a pretty easy place to start, I think.
Yes, I talked a little already about trying to find ways to do rotations or do different things. I'll also say that there are a lot of committees. The state has a lot of committees, and many of them need public members, and many of them meet in the evening. So that people that can work, certainly I got my start in Oregon, and I did a rotation, and then after that I was on a committee that met in the evening, and I was a resident, so I couldn't make every time. Sometimes I was on call, but it gave me sort of a different appreciation and insight into some of the work that happened, and then connected me to other folks. And I agree with Joe, just ask people questions, ask how you can help, and be open to what they say. There are certainly things that, I was like, this is what I'm going to do, but then something else comes up, and being open to those different things that come up can really lead to some exciting experiences.
It looks like everybody is still on. Allison or Pam, feel free to comment as well, but maybe I can pivot to a related question that you two might want to start with, which is, what advice would you have for physicians in training who are advocating for change in the healthcare arena? We might not have the background in public policy and advocacy that you two bring. So what advice would you have for us?
I would just say that I think, as Joe and Judy are pointing out, you don't know where you're going to end up. And so what's interesting is you might look at someone and think that they have a particular background and some specific experience that you need, but that's really not true. I mean, when Judy's talking about these committees, we need all different perspectives on those committees. So bringing your background, your expertise, even if it's not in government affairs or policy, is still really, really useful. And you'll learn those other pieces as you go along.
I would just add to get engaged with your state at the state level with legislation. If you find a bill that interests you, with either positively or negatively, to weigh in. I think your voice with your local legislators, even if they're not in your district, if they're on one of the committees of jurisdiction for healthcare issues, you'll find a ready audience, especially if you can persuade them to modify the bill according to your expertise. So get involved. We actually in North Carolina just elected a second physician to the General Assembly. We have one child psychiatrist, and now we have a second physician. So that, again, adds a voice and expertise, which is certainly needed in North Carolina.
I'll add, the barrier is lower than you might think. Elected officials, certainly state elected officials, but also congressional too, they or their staffs take meetings all the time with all types of people. They'll take a meeting with you. If you write enough letters to the editor, to your local paper, they will publish one. And if you don't do these things, someone else will, who knows less about it than you do. The barrier really is low. There is a void. It's easy for you to step in. If you don't, there's going to be someone that does, and they're not going to do as good of a job or care about it the way that you are.
Well, thanks. I can tell everybody's really engaged here. If people have 5 or 10 more minutes, I'll promise to wrap up by quarter after the hour, if not sooner. I see another very wonderful compliment, just to mention that people are really enjoying this advocacy grand rounds. Would love to see more of this topic in the future. One question from Arthur Chen. do you all have a sense that the state Medicaid innovation work can be foundational for a future unified financing model of universal coverage in our country?
So I'll maybe start. I think that's some of what I'm hoping to get towards with this multi-payer work on primary care, because I think if there can be alignment on a lot of things, like that's the next best step to a single payer system. No, sadly, the way the healthcare system is set up, I think it's going to be really hard to get to a single payer system, especially with the private equity interests that have really entered the healthcare space in the last couple of years, that sort of change things. That healthcare is set up as a business, and it's really hard to break that away. But I think there are things you can do by aligning some types of payment and aligning some of the administrative barriers and regulatory barriers to sort of make it more similar. And I hope that we can do some of that, because it is hard and it is not right for people that are not getting the care they need.
Thanks, Judy. Yeah, it reminds me of some of you in the audience may be familiar with the fact that two organizations came together as part of DFA a couple of years ago, National Physicians Alliance, and the tagline there was patients over profits, and the longtime tagline for DFA has been patients over politics. So for those of you who are interested to make healthcare better and truly achieve better health for all in our country, you're in the right place, and it's really great to have everyone here. Maybe as a quick wind up, I'll offer each panelist the chance to wave their magic wand and either say, like, if something that they're not working on that they'd be interested to work on in their state Medicaid program or at the state level, or something that they see in another state that they're really excited about. You want to start, Pamela?
Sure. Another, well, like I mentioned, this SDOH issue is all the rage right now. We're the only state that has a federal waiver and funding to ride along with that to implement a program. But, every state is looking at it in some way and just finding the best practices, because I think it is an important area, as you look at housing and food insecurity and interpersonal violence, toxic stress, things like that. Transportation is a big one. Really finding the synergies, the best practices out there, and is something I think I'll constantly be studying for the not too distant future, not too distant and distant future.
How about you,
And,
Joe? I
Jeff, by
learned.
the way, we got a question about HSAs, and I think that was directed to me. So I did put the response in the chat if if the questioner is still on the line for that one.
Great. How about you, Joe? I know we're talking about potentially a Hep C initiative here in Wisconsin, so I was really intrigued by that true population health initiative that you're doing.
I feel similar to Pam. I long for the ability to pay for services or goods or things that my patients need that are affecting their health, but just are not possible to be funded through a public Medicaid program right now. We spend 3 times as much on the back end dealing with the ramifications, when we could spend a little bit, help people out, get better health outcomes, but it's just hard to get that done bureaucratically, politically, so support.
Allison, you did a great overview of what's happening out there. Is there anything that you're seeing or hearing from members of your project?
Yeah, I think, it's what I described, but those closed loop referral systems. So as Joe's pointing out, there's just a lot of work that needs to go into making these referrals. So we're doing a really good job right now identifying the needs, but just struggling to make that connection piece to actually getting an appropriate referral and then finding out, how did that really impact a member's health? So I'm really just looking forward to seeing states can come together outside of Medicaid with the other agencies they need to work with to develop those systems.
Judy, you've got it all going on in Washington, but what are you seeing in other places that you'd like to see happen there someday?
Yes, we are doing a lot. I think some of what we've been following. Well, first of all, I'll say states are innovation. So it's very fun to like see what other states are doing and then steal from them. And sharing and stealing is something that the Medicaid medical directors do commonly. We have been following pretty closely Massachusetts, California, and Oregon's 1115 waivers because they've gotten some good things approved there, particularly with social determinants that I think is nifty. But I think if I could wave my magic wand, I'd want some better measurement to do something that's slightly different of how do we measure people's experience of healthcare and how do we get to really good health outcome measures. We measure a lot of processy things in our quality measures, and I really want to know, are we making a difference, and how do we tell? So thank you all very much. This has been great.
That's a great wrap. Thank you. Well, I'll just remind everyone that this session will be available later on DFA's YouTube channel. And as everyone has said, thank you to our panelists. Thanks to our staff for helping put this together. And thanks to all of you for being here and everything that you do on behalf of patients. And remember to follow us on Twitter and LinkedIn and Facebook and stay up to date with all the learning opportunities and advocacy opportunities provided by Doctors for America. Thanks so much, everyone. Have a great day.